Good afternoon and welcome to our third webinar. It is my pleasure to welcome Dr. Edouard Trabulsi, a urologist, and Dr. Robert Den, a radiation oncologist, who work together in a multidisciplinary practice at Thomas Jefferson University. Dr. Trabulsi is a professor of urology and is co-director of the Multidisciplinary Genomic Oncology Center, as well as the Prostate Diagnostic Center, vice chair of research and director of urologic oncology at TJU. Welcome, Dr. Trabulsi. Dr. Den is Associate Professor of Radiation Oncology, and with Dr. Trabulsi is Co-Director of the Multidisciplinary Genitourinary Oncology Center. Welcome, Dr. Den.
Thank you.
My name is Ryan Dittemore, and I'll be the host of this webinar. I'll provide a brief overview of Decipher and our genomic tests, and then hand it off to Dr. Trabulsi and Dr. Den to review the clinical data informing the decision to give early or late radiation therapy for men with adverse pathology post-prostatectomy. They'll provide their experience utilizing the Decipher test in a prospective study to inform timing of radiation therapy decisions and put the data in context to RAVES and Radicals data sets. Importantly, we'll examine case studies and also dialogue on how they are leveraging the genomic data to help with patient management of diagnostic procedures in light of COVID-19. So for those of you who are new to Decipher, we provide genomic testing exclusively for prostate and bladder cancers utilizing our CAP-accredited, CLIA-validated, and New York State certified clinical laboratory. Using this laboratory, we analyze biopsies and radical prostatectomy specimens. Specifically, we interrogate the tumor's whole transcriptome to provide the Decipher score. To date, we have processed over 90,000 prostate cancer samples, and as a company focused exclusively within urologic cancers, we've made a deep investment into the clinical development of our tests with prostate and bladder cancers. And as such, are involved in over 110 clinical trials or studies. As it says in the top right corner, we have been designated by the state of California as an essential business and are open and accepting patient samples. The lab is running 6 days a week, so if you have any samples of interest, please send them along. We have two categories of Decipher tests. On the left, the Decipher Prostate biopsy, which is intended for newly diagnosed patients and utilizes the needle core biopsy. For the biopsy test, we are covered by CMS and Medicare for NCCN risk indications. This includes very low risk, favorable intermediate risk, and unfavorable intermediate risk prostate cancer. Our biopsy test informs on active surveillance and definitive therapy strategies. Our Decipher RP on the right is for decisions post-op, both to inform on early radiation therapy decisions, which we'll be discussing today, as well as decisions incorporating the use of radiation therapy with or without ADT in the salvage clinical setting. Our products are in the NCCN guidelines for all the clinical indications I mentioned, including high-risk prostate cancer, which we are not yet covered by Medicare, but expect to gain coverage soon. Additionally, this year in the 2020 NCCN guidelines, our Decipher RP test was elevated to a recommend status. To our knowledge, this is the first time a molecular diagnostic test has been recommended for localized prostate cancer in the NCCN guidelines, and we're excited about the adoption of Decipher tests within the standard of care. We'll be focused on how we can use Decipher testing to inform on timing of radiation therapy post-radical prostatectomy. And with that overview, I'll hand it off to Dr. Trabulsi and Dr. Den.
Thanks so much, Ryan.
So thank you, Ryan. So what we see here is really what set the stage for the age-old question in urology, oncology: do we deliver radiation therapy post-radical prostatectomy or not? And so what you see here are two of the three phase 3 trials that randomize men after radical prostatectomy to either observation or post-operative radiation therapy. And what is seen in the literature and what's reflected here is that while both studies showed an improvement in progression-free survival, primarily being driven by PSA, when we looked at harder, longer-term endpoints, such as overall survival, there was a divergence between the EORTC study, shown here on the left, and the SWOG trial, shown on the right. Whereas the EORTC trial failed to show a benefit in terms of overall survival for post-operative radiation therapy, the SWOG trial did show a benefit for overall survival with a number needed to treat of 9. And there's been much written about these two trials, how we interpret these two trials, and what do we do with these data when we have conflicting data from phase 3 trials in terms of clinical management. Now, all of these patients had classical adverse pathology factors in order to be enrolled onto the trial, including extracapsular extension, positive surgical margins, or
Seminal
seminal
vesicle invasion.
vesicle. Thank you, Ed. Now, one thing should be noted here is that both trials had different schemas in terms of follow-up, both in terms of the recommended imaging that was necessary, as well as how often patients needed to come for follow-up. That resulted in different uses of salvage treatment, specifically salvage ADT, within the context of these trials. I think one thing that's important to note, and we'll talk about this further on in the webinar, is that one factor that came out from both of these trials was the importance of margin status in terms of benefit from postoperative radiation therapy. Now, coincidentally, both trials showed that at approximately 5 years, there was approximately 50% of the men on the observation arms who never developed PSA recurrence. So this set the stage for the guidelines, which Dr. Trabulsi is going to present to you in the next slide.
Thanks, Bobby. So to try to codify exactly what treatment guidelines should be recommended, AUA and ASTRO came together and put forth a combined consensus statement looking at high-risk patients after surgery, as Bobby mentioned, sort of the classic typical adverse pathologic features. So T2 patients with positive margins and any T3 patients, so either extracapsular extension or seminal vesicle involvement. And the recommendation on the basis of the RTOG trial, the German trial, the EORTC trial, is that patients post-op that have these adverse pathologic features should be offered adjuvant radiotherapy, supported by the data that showed reduced risk of biochemical recurrence across all 3 trials, reduced risk of local recurrence, and as Bobby mentioned, in the US SWOG trial, a more hard oncologic endpoint of metastasis-free and overall survival showed significant benefits. So this was a little bit of a sea change, and it was actually very refreshing that the urologists and radiation oncologists came together to have a combined consensus statement from both major organizations.
I just want to pick up on this last point. I think it's important to note that this consensus statement discussed and really highlighted the importance of conversations with patients with regard to postoperative management. So the statement did not come out strongly either in favor or against adjuvant radiation therapy, but really had a nuance-based approach. Now, nuance-based approaches are very interesting academically, but the question really comes when the rubber meets the road, how should the GU oncology community react to this type of data? Next slide, please.
And touching on that, Bobby, it's also consistent with the newer sort of approach to a lot of prostate cancer in general, the concept of shared decision-making. That's been sort of the mantra for PSA-based screening. If you look at other large medical organizations that have talked about PSA screening, we should have an involved and balanced discussion, not necessarily the paternalistic attitude of us telling people what to do.
Now, what you see here in this slide is the actual community use of adjuvant or early radiation therapy for patients. And so what you can see is just based on adverse pathology, the utilization of adjuvant radiation therapy is approximately 8 to 12%. And this is from Todd Morgan's group in Michigan, which is the MUSIC Consortium, which basically surveys urologists throughout the entire state on the use of different modalities. Now, this data tracks very well with what's seen out of the European Union with a decreased utilization of adjuvant radiation therapy. And part of this was driven that the EORTC and SWOG trials really were an observation versus postoperative radiation therapy. And many within the urology community thought that the better trial design would be to really utilize PSA to its maximum potential and really look at the differences between adjuvant versus early salvage, which these trials did not do. And thus, a lot of physicians decided to wait and watch to see what the PSA would do. Next slide, please.
So if we talk about why early adjuvant radiotherapy is underutilized, you can see on the left a lot of the sort of common concerns. These are both patient concerns and clinician concerns. And a lot of it regards around the expected or potential toxicities, both from a urinary and sexual standpoint, as well as certainly financial. And then probably, a more nuanced, understated aspect of all of this, especially amongst the surgeons, is this sort of concept that patients that go for radiation after surgery, it's sort of like a failure, that the surgery wasn't adequate. And one of the consistent themes in our multidisciplinary center, and Dr. Den and myself and our colleagues dating back to our bosses, Len Gamella, who's the chair of urology, and Adam Dicker, chair of radiation oncology, is to try to have a upfront discussion even before surgery to sort of lay the groundwork so that if patients that are high risk going into surgery do truly actually have adverse pathology post-op, that it's not a failure, it's not a bad decision, that's this is all part of our comprehensive multimodal treatment approach for the appropriate stage and risk of the patient.
And I think another very important point just to make on this is that in this setting, when patients have an undetectable PSA, when patients ask, do I have any evidence of disease? The answer is no. So also for patients, we see a whole wide diversity of patients. And with that, we see a whole wide diversity of risk profiles that the patients have. So some patients would say to Ed or myself, I want maximal therapy. So that would mean immediate radiation, hormone therapy, and sometimes we have a nuanced conversation with them about scaling back some of their treatment. On the other hand, some of our patients say, I'm fine, I don't want anything, I don't feel anything, I can watch this, and we all have these types of patients. So the multidisciplinary clinic, one of the features is also allows us to have multiple conversations with the patient, bringing up different aspects and bringing our different areas of expertise with the patient. I think one thing that is very telling, though, is while we rely extensively on PSA, it may not be the ideal endpoint that we should be looking at. Next slide, please. So this was a recently published paper. This is from the ICECAP group. So it was a brainchild of Dr. Sweeney, really pushed forward by the Prostate Cancer Foundation, where they decided to do a series of analyses looking for surrogates to overall survival. And this paper that was recently published in the Journal of Clinical Oncology looked at event-free survival, which was a PSA-based composite endpoint, and determined whether or not it was a bona fide surrogate for overall survival. So in order to prove surrogacy, there are a series of statistical tests that an endpoint must have. And if shown to meet these 4 endpoints, it can be stated that if you see a change in X, it will convert to Y. Now, after looking at over 10,000 patients from 15,000 radiation therapy trials with a median follow-up of 10 years, they did not find that the event-free survival surrogate endpoint met criteria for surrogacy. And thus, basing decisions only on PSA, while it may make us feel good, it may give the patient some assurance, it has not been shown to link to more of the harder endpoints like survival. And so we really stress when we talk with these patients the importance of understanding that PSA, while important, is not the only critical factor. And we really think about reduction of metastasis-free survival because that really speaks much more to survival.
The important other aspect of all of this is the disease, the natural history of prostate cancer. It's easy to have a lofty aspiration of overall survival, just like we see in lots of other tumors. But if you remember back to the Kaplan-Meier curves that we showed for the SWOG study, we're talking, years, if not decades, to get an overall survival endpoint. So the idea of having an intermediate endpoint makes a lot of sense in prostate, but the default to just say PSA, that does not shake out as being adequate as an endpoint. So this is a little bit of a frame shift, and actually in some of the newer treatments for prostate cancer, it's become accepted because of ICECAP and other studies that metastasis is a good endpoint and a good surrogate, and it's obviously much shorter in the disease course, so we can get answers quicker. Next slide.
So here is what you can see, the path and the life of a sample when it gets subjected to the Decipher prostate test. Now, this is true for both the biopsy specimens as well as the post-RP specimens. So what you can see here shown pictorially is that the pathologist will send the tissue which the urologist has removed, either through prostatectomy or biopsy. That tissue will then get subjected to an RNA extraction. It will get converted into cDNA and then undergo a whole transcriptome microarray. And essentially what you're getting is you're getting a small window into the underlying transcriptome. So you're seeing all of the coding and non-coding RNA transcripts that are present in the tissue specimen. These are then converted into a 22 marker set, which then gets converted into what we know as the Decipher score. And the Decipher score will give you back a report that will show whether the patient's genomic score is low risk, average risk, and high risk. And these are based on tested, trained, and validated cut points, and has now been validated in multiple other studies. And based on the risk that's presented, the report will show the risk of metastases and death from prostate cancer. Next slide, please.
So if I can interject just one other little piece to this. I'm commonly asked, what's the hassle factor? I get this asked from patients, I get this asked from clinicians. And so it does not need to be fresh tissue. It's taken from the biopsy that's in the file. So patients sometimes say, do you have to put me through another biopsy? A urologist say, if I want to send it, do I have to do something special? And then GenomeDx has done an excellent job getting the pathologists on board. So it's really sort of fire and forget. You order it, and then they are very good about going to the pathologist to get the appropriate specimen. And so you just order it and you get a report a couple weeks later. It does not necessarily add a lot of time to your very busy clinical day.
And just to pick up on this point, when Decipher was developed as a marker for early metastasis, and as we've already mentioned, the importance of metastasis as the endpoint, this was actually done originally from specimens from the Mayo Clinic from 1987 to 2001. And they had enough specimens where they were able to actually train and then validate on completely separate, unique specimens for this. And so these were all FFPE tissues from post-RP men, a 2-to-1 ratio of those who didn't have metastases to those who did. And that is how the Decipher score was determined. And the importance about this score is that it really reflected on a very broad view of prostate cancer pathology and metastatic pathology. So what you can see here is the different pathways that are involved. So classically androgen signaling, as you would expect, but you also see invasion metastasis, angiogenesis, metabolism, immune activity. All of these that we know are critical for cancer cells to both leave the primary as well as form metastasis in different areas of the body. But what you see here, and what we've done in validating it also through Jefferson specimens, is that even specimens over 10 years old can be subjected through this process through a very vigorous quality assurance to ensure, as was mentioned earlier, that it meets all of the CLIA, CAP, and NYS standards for the test. Next slide. So as I mentioned earlier, event-free survival was not shown to be a bona fide surrogate. However, metastasis-free survival was shown to be a strong surrogate for overall survival. And has been adopted by the NCI, by the National Cancer Institute, for endpoints to clinical trials that are currently ongoing and are being planned within the NCI framework. And the importance of this is shown here on the table at the bottom, where you see the treatment effect or the correlation between metastasis and overall survival with an R-squared of 0.92. Just to note, 0.5 is a coin flip, 1 is an exact match. So 0.92 comes extremely close to survival. And what you can see for PSA is that it's a very poor correlation between the two. And so what it really shows is the importance of metastasis as an early endpoint, as Dr. Trabulsi had mentioned before. And the interesting thing to note is that Decipher had the foresight to design their test to look at that long endpoint. And that's why the specimens originally from the Mayo Clinic and ones that have been validated through a number of the publications that you can see here were done from specimens from the late 80s through the 90s and even into today, because you need a very long clinical follow-up, as Dr. Trabulsi mentioned, in order to reach that metastasis endpoint. So I think this has really been the pinnacle study that's been done so far of Decipher in the postoperative setting. So this was a retrospectively conducted analysis from a prospective randomized phase 3 trial. This is RTOG 9601. So this was ideated in 1996. It took 10 years to accrue, and then 10 years of follow-up to be reported out originally in 2016, 2017, when Dr. Shipley reported at ASCO showing the benefit of the addition of 2 years of bicalutamide to salvage radiation therapy versus salvage radiation therapy itself. And then Dr. Felix Feng recently presented at ASCO GU on the analysis of Decipher in this clinical trial. So what you can see here is the 3 endpoints: overall survival, metastasis, and prostate cancer specific mortality. And what you see is that Decipher clearly and statistically differentiates survival amongst patients who are high risk, intermediate risk, and low risk in the entire population. So what you can see is that if Decipher was a drug, you would see that the Decipher Low would actually win out, as it were, and be approved as a new drug for the treatment of prostate cancer. But really what we're seeing here is the fundamental underlying differences in the genomics of the different tumor specimens. So while all of these tumor specimens clinically were indistinguishable between one and the other, genomically, they had many unique features. And this is something we see with our patients, where we'll see certain patients that have essentially the same clinical appearance, but have very drastically different steps. So the reason this study is so important is because it's the first study of a biomarker in the localized prostate space to be prospectively validated in a retrospectively validated in a prospective clinical trial. And so all of these patients had the exact same treatment, they underwent the exact same testing, they had the exact same follow-up. So any of the inherent biases that we've had in prior studies, including our own, have been mitigated in the randomized controlled trial.
And just to be clear, and you'll see going forward in all of the graphs with Decipher, it may be self-explanatory. The blue is the low Decipher score and the red is the high. And so you can see here on the left in the overall survival, the red genomic high did the worst. Next slide. So here, if you look at a bunch of different studies, Bobby's study using Jefferson data set, Jeff Carnes out of Mayo Clinic, Steve Friedland, Ashley Ross from Hopkins, you can see very consistent reproducible data that patients that have adverse pathologic features after surgery, and we send a Decipher and they have low risk disease, their overall risk of metastasis free survival over the next 5 years is in the high 90s to 100%. If you look at the different stratification variables at the bottom, the percent that were pathologic T3 as opposed to T2 with a margin, patients that got post-op radiotherapy, it's very consistent no matter what we do. Those patients all seem to do very well. And so this is very powerful information. You have a patient whose pathology makes your eyebrow go up, you're a little nervous about whether we're done with treatment. If they get a Decipher low, their risk of metastasis in 5 years is very, very low. Next slide.
And
Bobby, this is your paper. I have to let you talk about this.
No, Ed, it's quite all right. Yeah, so in this paper, I'll just say I'm very, very fortunate that I was able to put forward this publication, but this really is a testament to the multidisciplinary clinic and our multidisciplinary colleagues, in that it was because of the works of Dr. Trabulsi and the urology team, Dr. McHugh and the pathology team, myself and other members of the radiation oncology team, all working together and in tandem to basically curate a large clinical cohort to then be able to ask really critical questions. And this is something that, to Dr. Dicker and Dr. Gamella's credit, they had the foresight to think about 20 years ago to really build the foundation by which we could perform these types of analyses. So what you can see here in our study, we had about 50% of the men who had received adjuvant radiation therapy, 50% had received salvage radiation therapy. And this reflected on different physicians' preferences, biases, patient preferences and biases, but really had a good reflection in terms of what you would see clinically across the nation. And what we found was that for any patient that was receiving adjuvant radiation therapy, early radiation therapy, when they were Decipher low risk, when compared to the salvage radiation therapy patients, we saw no difference in cumulative incidence of metastases. Essentially, we had 0 metastasis at 5 years, whether the patients received early radiation or late radiation therapy. In fact, we did a further analysis looking at PSA, initial PSA, and the risk of developing metastasis, and we saw no correlation at all. So you could essentially treat these men with a PSA over 1, and they would not develop metastasis. You could treat them at a PSA of 0.1, and they wouldn't develop metastasis. This was essentially a very, very favorable group. And again, all of these patients had adverse pathologies. Now, this was in contradistinction to the Decipher high-risk patients, where we saw that with each increase in PSA, it was like a ladder, your risk of metastasis would go up. And when we compared adjuvant versus salvage, we saw that the use of adjuvant radiation therapy reduced the risk of metastasis incidence by 80%. And so a lot of people think that if you have a high-risk patient, essentially they have micrometastatic disease already. And this would suggest that further local therapy can play a critical role for these patients. If you can prevent the development of metastasis in these patients, what the SWOG and the EORTC and German trials showed is that they had decreased risks of needing hormone therapy in the future. They had improved quality of life. So what you can see here is with Decipher, we actually were able to separate what was previously thought to be homogeneous group of patients that we knew had a heterogeneous outcome, and we were actually able to put them into 2 different bins, into a bin of patients where we could just watch them, and into a bin of patients where we would advocate for further treatment escalation. Next slide. So after looking at this retrospectively, we decided, Ed and I talked about it, and we decided to really go full kilt, as it were, using Decipher. And so we decided to basically obtain Decipher scores on all of our patients. And then what we decided to do was to look at and base recommendations. And what we decided to do as a group was to have a uniform decision-making process. And so this is a study that we published. This was a resident of mine that was the first author, Dr. Marasio. And essentially what we did is we looked at 2 aspects. One is we looked at utilization around the country with Decipher, and we're going to get to that in a moment. But what we also looked at was, what was the outcome prospectively? We understood retrospectively, but some of the criticism that people had said was that these are old specimens, a lot has changed, surgical techniques have changed, perhaps we don't need radiation as much now because we've gotten better with our surgery, perhaps the radiation techniques have gotten much better now, and you're going to see different aspects. So we said, you know what, these are all valid claims. Why don't we test this prospectively? Next slide, please.
And this is our multidisciplinary workflow for patients. Some clinicians, when they hear multidisciplinary, they don't quite understand what it means. And we've really had a very robust multimodal, multidisciplinary approach at Jefferson dating over 25 years. So these patients come in to the radiation oncology clinical area. They stay in a room, and then we come to them. And so sequentially, they'll see everyone all at the same morning based on what their needs are, primarily prostate patients, sometimes some other tumor types. They'll see urology or surgical oncology, they'll see radiation oncology, they'll see medical oncology. Prior to the clinical visits, we will discuss every patient and review their pathology, review their records, review their imaging. So we have pathology, radiology on board, we have clinical research on board. We'll sort of have a game plan on what our programmatic recommendation would be for each individual patient, what, if any, clinical trials I might be eligible for. We're able to have sort of a real-time on-the-fly discussion, and it really helps patients when we don't come at them with sort of conflicting opinions. We're not coming across as salesmen. We're coming across as what our standard programmatic approach is for patients with their disease characteristics. And then it also gives credibility when, if we need to have another discussion after treatment about, after surgery, what should we do now? They know that we're already sort of putting our heads together for their best interest on what we should do next. Next slide.
And so based on using this framework, which Dr. Trabulsi had mentioned, so we had decided for the patients who had adverse path that we would decide, we would send a Decipher test on all of them. And then based on the Decipher test, we decided to make recommendations. So for patients that were low risk by Decipher, the recommendation that we recommended was observation based on the retrospective studies that I showed you before. And what you can see here is the patients that decided not to follow recommendations were ones that decided to undergo either radiation alone or radiation in combination with androgen deprivation therapy. And what you can see here is with 2 years of follow-up, and this is ongoing. So this was prospectively started in about 2017. So we're going to be updating this data in the near future. What we found was that looking at PSA recurrence, we could see no difference for the lower risk patients on PSA recurrence. So this matched essentially all of the retrospective data that we saw prior to this as well. Now, in the higher risk patient populations, our recommendation based on seeing the Decipher test was to recommend radiation therapy with or without androgen deprivation therapy. And the patients that didn't follow the recommendations were those that decided that they would want to have observation. Now, this was all done pre-radical and RAVES, which we will get to shortly, but this was a way that we decided to comprehensively look at our postoperative patients and really be able to come to a conclusion by having a uniform treatment approach for these patients. And so what we found was that at a year, about a quarter of the patients that were high risk by Decipher that decided not to follow the recommendation of treatment ended up having PSA recurrence and essentially falling into the early salvage patient group. So I think the important thing here to note is that, if you're thinking about a high-risk Decipher patient and saying, well, I'm just going to wait till they develop salvage, you're going to catch a lot of them very, very early on, which, before we didn't really have as much of this data to know what was the natural clinical progression of these patients. But you can see that within a year, a quarter of these patients had developed PSA recurrence. And again, this is still ongoing maturing data. So we are accruing more patients and following this as well. Next slide, please. What you can also see here in what we showed is that when we looked at a broader Medicare-based claims, we found that the Decipher test actually moved the needle in terms of clinician decision-making. So about 40% of physicians made different decisions on treatment after they received Decipher tests. And this is something that this actually validated an earlier study by Dr. Paul Nguyen. And what you can see here is that treating physicians were 9 times more likely to recommend adjuvant radiation therapy in Decipher high versus Decipher low. And I think one thing that both Dr. Trabulsi and I would agree to is that what we really want is to bring the right treatment to the right patient at the right time. And I think what this really highlights is that, for a lot of the patients that were Decipher low that we never knew about before, we were definitely overtreating them with any adjuvant treatment, whether it was adjuvant radiation primarily or even adjuvant androgen deprivation therapy. And in my mind, this was akin to treating low-risk patients back in the day with Lupron unnecessarily, as we've seen from multiple studies. But here, what we're showing is using a genomic-based approach to really separate these patients one to the other. And even though clinically they all look like they have more aggressive disease, genomically, they're really a unique patient group.
And if we expand on this a little bit, and we're going to see this in the cases that come up, Jefferson has, our multidisciplinary team has advocated for adjuvant radiotherapy going back 20 years. And we had a very sort of loose framework in the past. All patients with seminal vesicle invasion, we recommended radiation. Beyond that, if they had multiple risk factors, say T3 with a positive margin, we usually recommended adjuvant radiation. If they had less ominous adverse path, like maybe a focal positive margin, but otherwise organ confined, or a T3 with negative margins, we typically would follow those, but it was much less programmatic and algorithmic. And this is a real benefit of Decipher, is that it takes a lot of the sort of guesswork out. We just look at the risk category, and then we have a very standardized, all the radiation oncologists, all the urologists together, standardized approach on what we recommend. It reduces any sort of anxiety or sort of conflict with the patient when they hear the same thing from everybody. Next slide.
So this is data that was recently presented at ASCO. It hasn't been published yet, but it is very intriguing. It is the RAVES and radical data, where it really had a study that we as a genitourinary oncology community have been asking for years. I think these studies are akin to PROTECT in the definitive setting. So in RAVES and radicals, they compared the use of early salvage radiation therapy to adjuvant radiation therapy. And this was distinct from the 3 studies that we had mentioned earlier, where it really was observation versus adjuvant radiation therapy. And the truth is, in some of the studies, it was a mixture of both adjuvant and salvage radiation therapy. Here, it was pure adjuvant versus pure early salvage therapy. Now, preliminary results have shown that there is equivalency between the PSA event-free survival. Now, I think it's important to note that RAVES patients were lower risk versus what's seen commonly in clinical practice. So about 50% of the cohort had only Gleason grade group 2, which is 7, 3 plus 4, and only 17% were high risk with Gleason greater than 7. Now, the other thing to note about this is, while there's a lot of interest in the data coming out of these 2 studies, we had already noted that this endpoint of event-free survival is truly not a good surrogate for overall survival. So I think it's important that while we embrace the data that is there, we also think about it within the context of the endpoint that has been currently shown. So I think we really want to understand what the metastasis-free survival will look like in these 2 studies. I think it's important also to note that there was no genomics utilized in these studies. And we know that in general, genomics correlates with Gleason score. So although you can have patients with high-risk Decipher with a lower Gleason score, in general, the Gleason score will correlate with the Decipher score. So if we see a lot of low Gleason group 2 patients in the study of RAVES, we would suspect and hypothesize that they probably correlated with a lot of low-risk Decipher score patients. And as we had shown earlier, these patients probably very rarely need any treatment because their risk of developing metastasis is so low. Next slide. So as Ryan mentioned earlier, Decipher is currently recommended in the NCCN guidelines. As you can see here from the 2020 update to the guidelines, it's recommended to inform adjuvant treatment for postoperative RP patients in adverse pathological features. And that's essentially what we adopted very, very early on. I also want to point out that Decipher is currently being utilized in 2 prospective postoperative treatments, postoperative clinical trials. So as opposed to 9601, which is a retrospective analysis of Decipher in a prospective trial, this will provide, for the first time ever, a genomics-based biomarker in a prospective trial prospectively. So all of the patients that are enrolled on the phase 2 apalutamide trial by Dr. Spratt, which recently closed to accrual, they all received Decipher. And on Dr. Hurwitz's GU002, which is a phase 3 trial looking at the use of adjuvant docetaxel, all of these patients will also undergo Decipher. So we will be able to look at the importance of genomics prospectively in these cohorts. And I think this is a true testament to this test and to this company, because it's really putting skin in the game, as they say, to really show the value of the genomics, and it's reflected in the guidelines. Next slide, please. So as Dr. Trabulsi mentioned, I'm going to let him talk a little bit more about this. Within the community, there's a wide approach to treatment of patients with adverse path, specifically with T3A being extracapsular extension. One can take an adjuvant for all approach, a salvage for all approach, or more of a dealer's choice approach. And I think one thing we've seen in the literature is that, and this was published in the JCO by our colleague, Dr. Paul Nguyen, is that when patients are seen by individual practitioners, they tend to get treatment recommendations based on those individual practitioners. Whereas when they're seen in the multidisciplinary clinic, you really get a more nuanced type of conversation.
So here we have a patient, this is an everyday type patient, and, indicative, Bobby and I this morning saw, I think, 4 or 5 post-ops with adverse path, and this is exactly the sort of thing that we look at. Typical patient, 70, PSA of 5.4 pre-op. He's a grade group 2 on biopsy, stays a grade group 2 on whole mount radical prostatectomy, but does have extracapsular extension. Otherwise, negative margins, negative nodes. So this is a guy that we might be a little bit, conflicted. He's got a single adverse pathologic feature, not necessarily a dramatic adverse pathologic feature, negative margins. This is a guy that we would send for a Decipher. And if we look to the next slide, we can see his Decipher score was high risk. So a 0.89 translates into a 42% prediction of risk of metastasis within 5 years. Very significant number, that, as we mentioned by ICECAP, that is a surrogate for long-term badness. So 40% chance that he might, get into trouble. And if we look at a 10-year prostate cancer specific mortality prediction of 21%. So on the basis of this study, this assay, we would have a programmatic recommendation that he should get adjuvant radiotherapy. Anything else to add to that, Bobby?
I mean, I think it's very important because it provides patients with some real hard data to help inform their decisions. So we never go into the discussions with kind of edicts about what patients should do. These are still recommendations, still nuanced discussions. But in my mind, what we try to do is provide patients as much evidence as possible to really empower them to make the best decision for them and for their family. And just to remember that metastasis is so significant because it moves a patient from the curative state to the non-curative state. And this is something that we really try to emphasize to patients and make sure they understand. And as we're seeing patients now with a decrease in PSA, and due to COVID, less patients are coming in for screening, biopsies, et cetera, what we're seeing is a higher proportion of patients coming in preoperatively with metastatic disease. And not all of us, but some of us can remember what it was like in the pre-PSA era when we saw patients coming in essentially with incurable disease and not having good options for them. So here we have a patient that had definitive surgery, and probably in the past would have undergone observation, but now with the Decipher scores being shown the real risk. And so if you think about our study that we showed before, if we could reduce that risk by 80% through the intervention, we'd really be able to dramatically improve on them. Now, the other thing to note is that if you look here, this was a nomogram done by our colleagues, Dr. Dallela. And what you can see here in the nomogram is that if you look at Decipher, Decipher in and of itself is the strongest predictor of benefit from adjuvant radiation therapy, early radiation therapy here. So it's stronger than T3B or T4 disease. It's stronger than Gleason grade greater than 8, even lymph node metastasis. So Decipher score in and of itself is really a major driver for these patients. And so that's really what has been moving us towards really relying heavily on the Decipher for this. I think another point just to make is that, Ed and I are very fortunate in that we work in a very large academic center. We have a specialized pathologist who only reads GU pathology, but that is not always the case in the community. Sometimes pathologists are reading and have general expertise across multiple different pathology types. But what Decipher does is it actually, because it's so strong a predictor and because it's so powerful, it actually is a way to kind of do almost a central review of pathology by a genomics approach. And so what this allows you to do essentially is to gain a level of understanding of the tumor that kind of supersedes even what the pathologist will tell you. So we don't discount or discredit the pathology, but we allow the Decipher and the genomics to really help inform that decision, which I think is a very important point as well.
Let's, why don't we look at another case? So this is a 62-year-old gentleman. He was a grade group 4 on biopsy, grade group 4 on final surgical path. Similar sort of story, T3A with negative margins, negative lymph nodes. We sent a genomic on him, a Decipher RP, and that showed, next slide, a very low Decipher score. So if you look at the difference in the 5-year metastatic prediction from 41 or 42% down to 0.7%, a 10-year prostate cancer specific mortality prediction of 1.4%. And as Bobby mentioned, in the current turbulent COVID era, this is a guy not only would we recommend to avoid any adjuvant radiotherapy and all of the potential touch points of him coming into the cancer center to get his treatment. We might even increase his PSA surveillance just to space him out, keep him away, keep him safe. Hopefully that calculus will change as COVID recedes, but it's a real palpable concern that we have right now. This guy we would absolutely tell to stay away, see you back in 4 months, 6 months, and then quickly go to maybe yearly PSAs and keep him out of the radiation suite.
And I think the important thing here to note is that, again, if we had looked at these two patients side by side just clinically, one is a Gleason 4 with PT3A, and one's a Gleason 2 with PT3A. And we would have said for the Gleason 8, if we're going to treat, that's the one we treat, and the Gleason 2, that's the one we watch. But the Decipher flips it on itself. And here again, you can see that in the patients that have low Decipher, these are the patients where there's really no benefit and kind of further validates what we had seen previously. Next slide. And just to touch on what Ed was saying is that, we have changed the way we think about these patients, especially in COVID. We've moved all these patients from in-office visits to telehealth visits. We've also increased the spacing of their PSA testing. And especially for these low-risk patients where we think about competing risks. So now we think about competing risks not only of their heart disease, their lung disease, their liver disease, but also for the global pandemic of COVID-19 that's going on. And I just wanted to ask Ed if he could just touch on for maybe a minute on how telehealth has been utilized in our clinic.
Yeah, no, and Jefferson, luckily, even before the pandemic, had strides and a stated, aspiration to become a telehealth leader in the country. And now it's just having the infrastructure here already has just made everything so much easier. So basically, on the telehealth visits, and probably 90% of the patients are able in some way, shape, or form to get a video program, app, something working. That's dramatically better than a phone call. We set up, and we've even had multidisciplinary telehealth appointments. Bobby and I will see patients the same morning sequentially. We've even pre-COVID gotten into the same room and gotten on the same screen. We don't do that now, but and it's so well received. We've done some, we've had in the urology literature, we've published a couple papers on telehealth and urology pre-COVID, showing significantly improved, or maybe not improved, but very significant patient satisfaction scores. They like it much better than a phone call. And then now with COVID, it's an easy sell to just set up a telehealth. But the visual aspect just helps in terms of knowledge exchange and understanding of the patient sort of gets it. You can see much better than on a phone call if it's sinking in, if they're concerned, if we need to reassure them, if we need to go over it again. It's not just a 2-minute conversation, your PSA is fine, see you in 6 months. We can have this, I would argue, the same or nearly the same level of counseling and discussion that we do an in-person visit. And so it's really it's really lowered everyone's anxiety. A lot of patients are worried that they're sort of floating out there with COVID, and we can have in-depth conversations and counseling without really losing very much. And Bobby, I think you'd echo the same thing. I mean, it's really been quite amazing how well received it's been with patients.
Yeah, definitely. And I think that also the thing, to Ed's credit, is that, we were able to quickly transition the multidisciplinary conference using Zoom and other platforms immediately. We integrate still pathology, radiology on all of this. We have comprehensive discussions on these patients. And I think the other point to take into mind is that with COVID, we really weighed a lot on the Decipher and said, if these men are low risk by Decipher, these are men where if Ed only has, 5 spots, because of telehealth or because of other considerations, we know when we've started to allow for some patients to come into the office, we really have to be very, and I imagine most of you as well, have to be very vigilant about which patient we see and really prioritize those that are in highest need of our care immediately. And these low risk Decipher patients are men in whom we can really push off, and in Pennsylvania, where we both practice, we've seen a decrease in the case numbers, a decrease in the deaths from COVID. So it's really allowed us to kind of move patients further out and really decrease their risk from this. And we've been able to do it really in a very systematic and a very safe fashion, because we know that that risk of metastasis is so low. The high risk men, by Decipher, in contrast, those are the patients that we really are aggressive about ensuring we have follow-up and making sure we have multiple visits set up for them. So it's really also changed. We don't take a follow-up one-size-fits-all cookie-cutter kind of approach. We really make it nuanced based on the genomics. Next slide, please. So again, as Dr. Trabulsi mentioned, for the PT3B patients, we really had taken an adjuvant for all, really based on the SWOG trial early on. Next slide. And so
this
here,
is a,
please.
I'm sorry.
No, please.
So a 64-year-old gentleman, he was a grade group 4 on biopsy, downgraded to a grade group 3, but did have seminal vesicle involvement, an extracapsular extension, negative margins, and we sent a Decipher on him. Next slide. And this guy also had very high, one of the highest Deciphers we've seen, 0.97. So his risk of 5-year metastasis of almost 60%, 10-year prostate cancer specific mortality risk predicted at almost 28%. So it's fairly consistent with his surgical path, although we would have thought with the Gleason downgrade that we might not have been so concerned about this guy. But this guy, we would not only recommend adjuvant radiotherapy, but we might consider adding in short duration androgen deprivation therapy. If we come, next slide. If you look at sort of a waterfall plot of where these patients fall, he's at the far right. So he's got one of the highest risk of metastasis that we've seen.
And I think the other point, just to jump on, is that what you notice right away is that this is not a direct linear plot, but what you can see is that there's a very large range, even within the high risk, and it's continuous. And as you can see here, the risk really jumps up very quickly. So it almost goes exponential as we move up in Decipher scores. So even if you see the Decipher score difference of 0.6 to 0.61, that can have a significant increase in patients' risks of metastasis. Next slide.
Now, this is another patient, also similar grade group, also seminal vesicle involvement. We ran a Decipher on him. Next slide. He also was very high risk, not quite as high risk. This guy, for a variety of reasons, we recommended adjuvant radiotherapy alone. Between his patient characteristics and his Decipher being a little bit less ominous. So you can modulate it based on both the clinical pathologic data and the comorbidities and age. Next slide. And you can see where he falls on the risk category, sort of dead set in the middle of the high risk patient cohort. I know we're running out of time here. If we go to one, this was a young guy, grade group 2. He had multiple adverse pathologic features, extracapsular extension, seminal vesicle involvement, and positive margins. We ran a Decipher on him. Arguably, we were going to think about radiation no matter what. And lo and behold, he's actually a low risk patient. So especially for a young man that we might in the past be very aggressive with, but might also suffer from some of the quality of life toxicities even more acutely, this guy we're very comfortable with recommending close care for follow-up. And we instill on him that we need to make sure we get PSAs regularly. We're not going to just go to once a year PSA, but with telehealth, it's easy to get these patients in, but we're not going to necessarily slam him with more treatment. And he was very happy with the idea, just keep an eye on things, and we were comfortable with that. Next slide. As we draw to a close, I'll let Bobby take it home.
So, I think the things we wanted to get across during this webinar is that, the decision to deliver early radiation therapy is complicated. The randomized controlled trials and guidelines that support improved efficacy, but not all patients benefit. And we know that we may be increasing risk and side effects to low-risk patients. Decipher improves our ability to estimate the patient's metastatic prostate cancer-specific mortality and overall survival risk. And what we believe is that the data supports the use of early radiation therapy in the Decipher high-risk patients and really supports the use of observation for the Decipher low-risk patients with salvage therapy as needed. We almost have moved the needle, as it were, almost to where we are in testicular cancer, where we really look at risk and have nuanced conversations with these patients and really try to push those that don't need treatment to observation as much as we can. Next slide.
Great. So thank you, Dr. Trabulsi and Dr. Den. We do have some questions, so and we do still have a number of people on the line. So if we could stick around for a little bit, and if you're on the line and still have some questions, please enter them in right now. But if I can go ahead and get started, actually, Dr. Den, this is a question that was asked on your JCO 2015 study, how you defined early salvage versus salvage radiation therapy.
That's a great question. So if you look in the manuscript, we talk about it was 0.1 or less was considered early adjuvant radiation therapy, and 0.2 and higher was salvage.
Okay. And Dr. Trabulsi, this is a question for you. Given the current situation with COVID and the limited ability to perform radical prostatectomies, do you see a role in Decipher in prioritizing patients for surgery?
Oh, absolutely. I mean, we've been focused exclusively on the post-op patients, but using the Decipher biopsy test in some of the borderline questionable sort of intermediate risk patients absolutely can help us decide when we want to bring them in, whether it's safe to wait or not. And it's so troublesome for all of us because there really is no light at the end of the tunnel. So we don't know when everything's going to get back to normal. So it gives us another data point, and then the patient and the clinician together, and it's based on local infection rates, local shutdown rates, PPE. You have a little more flexibility based on the individual hospital setting on when it's safe to bring patients in and when we should defer it. And so it absolutely can help in that. Even if you kind of know that they're going to be treated at some point, if you get a Decipher biopsy that's reassuring, then you can put it off and wait a couple months, 6 months, whatever algorithm fits with you as we see how the pandemic plays out.
Right. In that last patient, the 46-year-old patient, his Decipher score was a 0.45, which is technically in the average range. It's really close to low risk. Do you lump the average in the low risk, or do you just look at the kind of the continuous score of the metastasis risk survival? How do you use that score in this question, in this clinical decision?
Bobby, you want to talk to that? I mean, I know that different papers have addressed that differently.
Right. So in some of our papers, we differentiated the intermediate Decipher score. In our prospective study, we included the intermediate with the low, and we had pushed those patients, because if you go back to that waterfall plot, you see it's really kind of more of an exponential plot. So in our minds, we arbitrarily or not, we included the intermediate risk patients in the lower categories. I think one of the things that I talk to the patients about is where their risk profile is and where their risk threshold is. And I think we alluded to this earlier, but for some patients, 5% of a risk is too high. And for the radiation oncologists, when we talk to women who receive radiation therapy after surgery for breast cancer, a small change in percentage can have a huge magnitude on what women will choose to do or not to do. Men seem to not be as medically risk adapted as women are. So women will undergo a tremendous amount of increased therapy to decrease risk, even by 1 or 2%, whereas men tend not to be. But I think it's very important to have that conversation with the patient. And again, that's where the actual numbers can help you have that conversation with the patient so that they can understand, is a 5% risk, that's a 95% risk of not having any problems in 5 years. And so that helps them kind of put everything into context and really weigh the decision in a much more nuanced approach. So just in general, please ahead.
When we talk about the Decipher results, we don't just show the arrow or the color. We definitely go into the details of 5-year metastatic risk, 10-year prostate cancer specific risk, and some patients, it just goes right over their head. They're looking at the colors, they see red, they're worried, they see blue, they're fine. But there's a lot of, probably the majority of patients really do sort of get it, that they decide which number worries them or not. So I've had some patients that say, even if they're high risk and see 40% chance of metastasis free at 5 years, they said, well, doc, that means that most men aren't going to get mets at 5 years. I don't want anything else done. And you've had a discussion, you talk with them, and they have a personal part to play in all of this. And like Bobby says, some patients that I'm counseling, trying to back them off the edge of the cliff, they see a 6% risk of mets at 5 years and they're going crazy. And so since it's a continuous number, we don't, even though we have our arbitrary cut points, we let the patient get involved on their comfort level based on those numbers.
But I just want to touch on this exact point that Ed's bringing up, is that it also allows us to think about resource utilization and resource allocation. So we have a coordinator of our clinic who's in charge of contacting all the patients and ensuring that everyone's appointments are made, and she's also instrumental in follow-up for these patients. So in a man with a very high Decipher who says, in the exact scenario Dr. Trabulsi just mentioned, 60% chance that I won't have anything happen to me, I can watch this. So that's a man where we're going to really be vigilant about having our coordinator chase after him to ensure that he's at least getting the PSA follow-up that we need, as opposed to a patient who only has a 2% risk of metastasis. That may be a patient where we put more of the onus on follow-up on the patient and on the primary care physician. So I think that's also another important aspect to think about, is that when you only have a certain amount of time and a certain amount of energy, and you know that you can basically determine which are the patients that are the highest risk from dying from their cancer, you really want to put your energy and effort on ensuring that those patients aren't lost to follow-up. And that's kind of where, when I said earlier about thinking about it like testicular cancer, in testicular cancer, we've moved as a field in the GU field dramatically to observation for these patients in the stage 1 seminomas. But that's predicated on the idea that these patients will have good follow-up. So on patients that we're concerned about their follow-up, we're going to be much more vigilant about following them up. So even more acutely now in the setting of COVID, where things are a little bit more challenging to manage, this is where we really think within the multidisciplinary context, which are the patients that we need to ensure that if they miss that 3-month appointment, we have an automatic follow-up for them to ensure that we can catch them before they get to 6 months and come back with a PSA if they were undetectable initially, now of like 0.5 or even 1, which we can sometimes see in these high-risk patients.
Okay, so we have actually a couple other questions I think are important to address. So one is, Dr. Den, for you in terms of the field, and do you use the Decipher score to think about, pelvic field or regional, targeting the lymph nodes in this adjuvant setting, or how does Decipher inform and how do you apply the radiation?
Yeah, so that's a great question. Unfortunately, there's not a lot in the literature. There's 1 or 2 papers that have been written looking at Decipher and lymph nodes specifically. So what I generally do is, yes, I'll use Decipher to think about the lymph node. I'll also use the clinical context. Were they high risk by Gleason score or by PSA, and that would help me determine whether I want to treat with pelvis fields or not. I think the whole question of pelvis fields is still controversial. We're waiting for RTOG 0534 to be published by Dr. Pollack. And again, we're waiting for the real hard endpoint of metastasis-free survival. The other thing that I look at a lot is the pathology specimen and talk directly with Ed about the case. Were there nodes or were there areas that he was questionable about? How many nodes did he get out? Some cases there'll be 5 nodes removed. Other cases there could be 20 nodes removed, and he'll tell me he takes out the same amount of fat packets. I think it just depends when the pathologists are looking through this. Sometimes you have that junior resident who's kind of chopping through everything, and they will serially dissect and find all of these lymph nodes. So I also use the lymph node count to understand, if we get 20 lymph nodes out, my concern about lymph node involvement is decreased dramatically. Whereas if we only see 1 or 2, mainly from outside referrals, that will be where, if I see it in the context of a high-risk Decipher, I would think about pelvis treatment as well.
Okay, and the last question has to do with using Decipher in terms of giving maybe a short course of ADT in the adjuvant or early setting, and we showed that one case with very high risk. And I guess just kind of contemplating, how frequently do you consider that? Are there specific patients that you address that to? When is that something that you pull a trigger on early versus waiting in the salvage setting?
That's where RTOG 0534 might really help us. Or is it 0521? I always mix those up. But there's the post-op where they looked at 3 different regimens of post-op radiation. The very simple answer that I have to patients, and Bobby will expound on this, is that we absolutely use the numbers and the risk profile to decide when and how to escalate treatment. So not only whether to treat or not to treat, but that gets into the question, ADT with it or not, pelvic nodes with it or not, it all goes into the picture, and it's very much sort of a risk-benefit analysis that's not currently data-driven. We don't have a landmark paper or a guideline to point to, but it's our clinical gestalt on how worried we are about these guys. And would you agree with that, Bobby?
Yeah, I mean, I think one of the things that I try to do is to kind of put it into context. And so what I always try to do is ensure that we're providing both the potential benefit as well as the side effect profile for androgen deprivation therapy. And a lot of times the men that we see in the clinic kind of have strong opinions about androgen deprivation therapy, either for or against. And again, it just gets into this idea about really empowering the patients to understand the risk profile, understand what the benefits that have been shown with the use of androgen deprivation therapy are. Essentially, all node-positive patients, we will recommend 24 months of androgen deprivation therapy with radiation therapy. For the patients that never that never nadir post-op, even if they're node negative, those are patients, again, where we're going to promote either the NRG trial, or we will strongly recommend androgen deprivation therapy. In those men that nadir and then develop PSA recurrence, depending on what their PSA levels are, If you look at the paper that was published by Dr. Spratt on the analysis of RTOG 9601 showing the benefit of using PSA to determine the use of bicalutamide at least. But again, as Dr. Trabulsi mentioned, 0534 will provide a lot of insight into the use of hormone therapy. So I think we look at the clinical factors. Were they a high-risk patient preoperatively based on Gleason score and PSA, and that would then give us more reason to give hormone therapy? What's the patient's understanding of hormone therapy? How do they view themselves within the context of hormone therapy? I think these are very important, but to Dr. Trabulsi's point, we don't yet have definitive information on this. I will say that there are some studies in the works that we've looked at using Decipher, because the Decipher is looking at a microarray and allowing us to look at over 1 million markers on that microarray. We have developed some preliminary markers for the use of androgen deprivation therapy, but it's not yet ready for prime time, as they say. But I think you will see this being utilized more and more in prospective trials, and I anticipate that in the next several years, we'll have a lot more data on this specific question about determining who benefits from androgen deprivation therapy and utilizing a predictive as opposed to a more prognostic biomarker.
Great. Well, thank you very much both. Thank you, Dr. Trabulsi and Dr. Den, for your time today. Thank you to the audience for joining. And I think we addressed all questions. If there are any other questions, we'll follow up with you individually. But thank you, and look forward to seeing everybody on the next webinar that we'll host. Have a nice day.
Thank you all very much.
Thank you. Thanks so much.
Bye-bye.